Hello, everybody, and welcome to this week's episode on Fit as a Fiddle. Today, our guest is a renowned neurosurgeon. We're going to have a treat today because he's going to be talking with us on everything regarding back and neck pain and minimally invasive surgery. Who we have today is Dr. Osama Kashlan. He is the director of spine surgery at York-Presbyterian Brooklyn Methodist Hospital. And he also has a subspecialty in minimally invasive spine surgery. And he does all kinds of things, including motion sparing surgery, which we're going to hear about because that was new to me when I first started learning about him. And then, of course, he, being a renowned surgeon, he has so many other things under his belt, including publications. He's an officer in the Air National Guard and all sorts of really amazing things. We're really lucky for him to make time in his very, very hectic surgical day to spend time with our guests. So thank you, Dr. Kashlan, for being here.
Thank you so much for having me, giving me this opportunity, and thank you for the super kind introduction.
Absolutely. All right. So let's first get started with the things that you do because, minimally invasive surgery is a very, very big field now. I mean, over the last, I'm sure two to three decades, there's so much more research and a lot more innovative things, including even the robotics and the tools that you guys are using to even conduct these surgeries, let alone what the surgeries even are, right? So, just knowing that you have entered this field and it's the subspecialty, can you just tell us what made you want to do this?
Yeah, no, I mean, I think it's an exciting field to be in right now. There is so much that's changing. There are a lot of patients that I'm seeing in clinic now, and I tell them, we could offer you this surgery, but I know what's in the works. And 5, 10 years from now, the surgery that I'm offering you is probably going to be something that is outdated. So it's an exciting time to be in spine surgery. It's an exciting time to be in the care of spine patients because of that. So really, when I was in medical school, I didn't think that I wanted to be a surgeon. It's actually all happened by chance. I thought I was all about global health, emergency medicine, primary care, and was really going down that route. And all it took is, I did my surgery rotation and I took the toughest rotation because I said, I'm never going to be a surgeon. Let me just take the toughest rotation so I could just experience it. And I used to round on all the patients and really take care of them on the floor post-operatively. I never went to the OR because I said, I'm not going to be a surgeon. Why would I go to the OR? I want to learn how to take care of patients. And one day, one of the mid-level or senior residents said, you're working really hard. You're here early. You're here late. Why are you not coming to the OR? And I told him, I'm going into internal medicine or ER. I'm not going to be a surgeon. Why would I just stand there when I can learn all these things up here? And that's when he said, come down with me. And we went down and did this huge abdominal operation. It was like 8 hours, and he really let me do a lot as a medical student. And when we got done, it was 8 hours later, and it felt like 2 minutes. It really felt like nothing. And that's what changed my life. So it's interesting to see how one person's action, and all of us have that power, can really change someone's life in a way that I'm not sure this guy even remembers that he did that to me.
No, probably not. That's really, really a cool story. Especially that you didn't even want to go to the OR in the first place.
No,
It would be
none.
one thing if you're like, I'm actually going to do this and I'm exploring it. But it's even cooler to not think that you wanted to do it and then end up your whole life. That's amazing. So tell us a little bit about, you're involved obviously at Weill Cornell. You're involved with NYP or Brooklyn Methodist. You're in New York now and involved in all these different things. So what is your primary role? And what does your day look like pretty much?
Absolutely. So, I am new in New York. I moved here in January. I was hired here to be director of spine surgery at the New York Presbyterian Hospital in Brooklyn. So it's NYP, Brooklyn Methodist. And their goal is to build a robust spine program here that includes all facets of spine care, including taking care of patients with degenerative conditions that could benefit from minimally invasive surgery, taking care of patients with spine tumors, taking care of traumas, really all facets of spine care, including working with the non-surgeon docs and physical therapists and the rest of the team that really are all super important in delivering care to patients in Brooklyn. So really the goal here was to build a program that, we say it's going to be Weill Cornell 2.0. And that's really why I was hired here. In terms of your day-to-day activities, so it's very different being in this type of role when comparing it to where I was before. I was at the University of Michigan and practiced for 5 years. So where there, I felt like I was more of a, foot soldier, meaning taking care of patients, which I love, and doing things one-on-one. The role here is a little bit bigger than that. I'm still, have the honor of taking care of patients and taking care of people with spine problems, but there's also an aspect of this that is more organizational, building relationships with all the different providers that are important in spine care, and also building a brand in Brooklyn, and showing everybody that we could do the top of the line care. You don't have to go to Manhattan to get the top of the line care.
That's
So it's
really
very
cool.
different here.
Yeah. And all the top of the line care in Manhattan is also like concentrated in this like very small radius. So, and it's funny because a lot of my patients, when I get the scripts from their doctors, it's always from that general region that we all know of. So it's good that we're expanding because that's what we need to be doing. There's phenomenal doctors everywhere. So Brooklyn needs a good set of, eyes on this new field too, because I'm sure that part of the reason why it's been so concentrated for so long is because it's hard work and it's a lot of work and it's very specialty work, right? Would you agree?
Absolutely. I mean, I think it takes a lot of training to do all the things that we do, all of us, you, me. I mean, it really takes a lot of expertise and time and effort and hours, honing your craft. So it takes a long time, but it's also really, really nice. We're in a special situation here in New York City where it's so concentrated. So where you have this big hospital in Brooklyn, where in other areas of the country, it would be probably like 100 miles away from the mothership. Where
Mhm.
here, I mean, I'm still going to conferences there. I have their expertise to rely on. We have joint conferences together. We met at one of them. So it's really an incredible opportunity to build a brand, but still have the support of such a renowned organization with great surgeons and great physical therapists and great providers like they do in the Upper East Side.
Yeah, wonderful. All right, so let's shift gears into back and neck pain. So I know that, with the approach that you guys have, well, for listeners to reiterate what you said, we met at a conference for back pain,
Mhm.
which was really amazing. And so there are ways to look at back pain. There are different professions, different in a multidisciplinary approach. We all look at back pain in different ways in order to care for a patient in the most holistic and comprehensive way that we can, which is the whole point of the multidisciplinary team. So can you walk us through with the work that you do, what is the approach that you and the people that you work with, kind of provide, and what approach you guys use when you're specifically talking about back and neck pain? And also, how is that different from maybe the way that you thought about it a couple of years ago?
No, I think that's a great question. So the first thing is that when we're looking at a spine patient, which is different than we were in the past. Before, we were very siloed. If you came to a non-surgery pain doctor, so pain specialist, you would get a different treatment plan than if you saw a physical therapist first, than if you saw a surgeon first. And I think the same lesion, you would see them go down different paths. That has changed now. I mean, I think Weill Cornell in Manhattan has been really one of the role models for the whole country on building a multidisciplinary spine program. And that's something that's completely different about approaching a spine patient now. We're discussing patients in conferences together with all the expertise. For us, every Wednesday, we have a conference where all patients that are not straightforward, all conditions that are not straightforward are discussed between all the providers, surgical and non-surgical, from all NYP campuses. So that's a way that we're treating patients that's different. And I think that has to do a lot with, I think as we are, I'd say modern times, we are becoming a lot more inclusive of other people's ideas and thoughts. And also a big thing is, historically, surgeons, neurosurgeons, spine surgeons, I think had very big egos, and you had to take that into account when you're taking care of a patient. I think now we all look at things as if we're brothers and sisters, and we're all just as important for the care of the patient. So I think that's the biggest thing. Um, the other thing that's very critical and different now about the way we approach spine patients is all the technology that we have allows us to do things that we couldn't do in the past, um, unless we were doing a huge operation. So things that took a huge operation to do, which when you're discussing with a patient, but the risks versus benefits for a big operation, it's a lot of risk. So the amount of risk that we're taking to give someone a benefit is different than it is now. Now, with the use of robotics, which have infiltrated into spine, the use of endoscopic surgery, which allows us to use angled scopes to get into areas that we really couldn't do in the past without disrupting a lot of the tissue that is around the spine. And a lot of the technology that goes into the hardware that we put in and a lot of the biologics that we put in really enhance the ability for the patient to recover well and have a great outcome at the end of the day. And really what's coming even further now is using augmented reality and virtual reality for surgery. And even further than that is how AI is slowly infiltrating into surgery to allow us to make the best decisions for surgery or for our patients. Kind of like what I was talking about earlier. If you saw a different person, you were going to get a different type of surgery, different type of therapy. But I think with AI, we're going to be able to put it all together and figure out if you have this is what you should get. And everybody will standardize the way that they approach patient.
That is so cool, and I have so many questions. Okay, so first off, okay, this is a really stupid question, but I've always wanted to
No.
know this. So going from like medical school and your residency and your fellowship and all of like the training that you're doing in, I guess, whatever ways you guys used to do surgeries to that transition of now, like I'm sure even in the last like 4 or 5 years, the introduction of so many, there's so much technology basically in every capacity. Like, how did that feel like switching? Like, was it kind of like going from like a dumb phone to a smartphone suddenly, where you're like, what is happening here? How did you feel, and what was the process? Especially even like, I know you haven't been a surgeon for like 50 years. I don't know if there's 50-year surgeons. By the time you're a surgeon, I feel like everyone's 50. But what about those like even like older people who are like also like so intelligent, and then they have to switch into this thing because it's better for their patients and it's better for outcomes, and that's what you do, right? So that's a stupid question, but I really am curious.
No, honestly, it's a phenomenal question, and it's a decision that, as a society, we are facing, not just in medicine, but in everything else. Specifically in spine surgery, because that's what I know. There is always initially an angst or a fear of new technology from the older generation. I'm saying, I'm not uniformly saying that, but in general, um, I think the time point where older surgeons take a new technology is a lot further than a young surgeon, because they know, like, they've honed their craft so well, they have such great outcomes. They have to wait until the technology, because everything at the beginning is, it's going to take some time for people to use it well. So I think they are understandably very anxious about taking something that is going to maybe decrease how well their patients do, at least temporarily. So I think there is definitely a lot more young surgeons that take up new technology. I recently was listening to a talk and I don't remember the specific timelines, but they were saying that a medical student, what they learn in medical school used to be valid for, I don't know, 10 years, 15 years, whatever, before they had to redo their education. But this speaker was saying that it's actually in the order of weeks now because of all the new things that are happening in medicine. I'm not sure, where that data was coming from, but it shows how this time and age things are just changing so fast. So um, I think younger surgeons probably take it up faster than older surgeons, and I think it's unfortunately critical in this time and age to pick up new information. One of my biggest mentors in spine surgery told me that the way I'm doing things now is nothing like what I did in residency. And that speaks volumes to that person's ability and will to innovate and continue to give their patients the best care.
Yeah, it's hard work, I'm sure. Like even just taking what for us it's called CEUs, CMEs or
CME, yeah.
CMEs for you guys. It just takes time. Like I'm licensed in 3 states. By the time I finish taking 2 years worth of coursework, I'm like, oh my God, here we go again. Another 2 years worth of coursework, right? So I'm sure it's exhausting and just learning. And also like, I guess for me, it's not like I'm learning like completely different new skill sets. It's like I'm adding to my skill set, if that makes sense. It's like
Absolutely.
I'm adding to my toolbox, but I feel like in your situation, you're actually like changing the whole tool set. It's going from like wood to like metal.
It seems like it, absolutely, in some things, for
That's
sure. It's a great
crazy.
analogy.
Okay, so I want to go back to something that was in your bio that I actually am curious to learn more about, and I'm sure the listeners are also curious about too. So you said motion sparing options, and that's something that you specialize in. So I want you to walk us through what that means and what you're doing.
Absolutely. So when a patient comes to you with neck or back pain, the first thing that you want to do is make sure that all the non-surgical measures are done. You want to make sure all the procedural stuff that are important for the patients, whether it's steroid injections in the back, whether it's some type of procedure that pain doctors do, you want to make sure all that is exhausted before you get to a surgeon, assuming that you don't have any type of significant neurologic deficit. So when a patient comes to me, my goal is to give them the least invasive option to treat their pain or treat their symptoms. And what that entails are two things. One is you want to go through natural tissue planes because that minimizes collateral damage when you get to your or as you get to your target. So
Mhm.
that's the important thing about, in my opinion, endoscopic surgery allows you to really minimize the collateral damage and get into areas where historically you had to remove so much bone to get to the regions that you had to fuse the spine. Fusing the spine meaning put screws in and take motion away. So that's very important when you see a surgeon, is to make sure that that surgeon that you're seeing has exhausted all options that are non-fusion options. So what other motion sparing options are there? So over the past 20 years, technology has improved drastically in terms of performing disc replacements. So it used to be where if you have a bad disc, let's say in the cervical spine in the neck or in the lower back, you used to go in, take the disc out, put in a cage in there, and then put screws or cages or rods, pretty much take the motion away. That was the paradigm, that was the treatment algorithm for these patients. You take the micromotion away and they'll feel better. And they do. But the problem when you take part of your body that's supposed to move and it doesn't move anymore is that it puts a lot of stress on the levels above and below where that fusion occurred. So what happened since then is over the past 20 years, they've really improved the technology to, instead of putting a spacer when you take a disc out, put in a disc replacement, a fake disc. Usually it's a metal or some type of plastic metal combination that allows you to move in those areas. And that minimizes the chance of having a problem the level above or below where the surgery is because it minimizes the pressure on those levels. And even more recently, so that's a disc replacement. So if you have a problem in the disc, you replace the disc. But there are other parts to the spine. There are facet joints. There are other ligaments that are there. So one of the newest technology that is one that came out, just became FDA approved, is a facet replacement device, where if you have a problem with overgrown facet joints, and those are what's causing pressure on your nerves, you can remove the facet joints, and where historically we used to fuse those patients, take the motion away. Now you could put this facet replacement device, and that allows you to move in that area, minimize problems above and below. And there are even more advanced uh, technologies in the pipeline, not FDA approved yet, that replace both the disc and the facet joint, and could be something that would change the way that we approach spine surgery, where maybe no patients or very minimal patients need to go through with the fusion.
That's really cool. Yeah, I know tons of people with fusions above
Yeah.
the age of 25, 30 when they were like young and they had something happen to them. And it's funny because like I always, when we're thinking as physical therapists, we're always taught like when somebody's coming in, even if it's like like upper extremity, lower extremity, like they're coming in for like elbow something, you always screen the joint above and below because those joints are influencing what's happening at the problem joint, right? And usually if there's like a tightness or weakness problem in one area, it's because of some compensation of tightness or weaknesses in other areas. And not even just talking about referred pain, where it's like actual referred pain, but it could be like non-referred pain that's also being caused by just orthopedic issues elsewhere. So yeah, going back to what you were saying about causing excessive motion, that makes total sense to me that that's what would happen. And even when we're thinking about like spine protocols, like when PTs treat, initially you're not supposed to really like move around that area, right? Like the traditional like log roll, like you're teaching the patients. I remember doing an acute care clinical rotation, and it was just like so much of just like, you know, they're just gotten out, it's just healing process. You would see them in the clinic like a couple of weeks later, everything is like work on things outside of that joint because or outside of that area because we still need so much time because it's been so invasive for those tissues to heal. You don't want to move things around that area, but as PTs we focus heavily on strengthening and mobilizing things outside of those areas of this actual surgical part, where the surgical surgery happened. And that's because other things have to work harder. Even if you think about like an amputee, right? Like somebody who has like some lower limb amputation, one of the first things the PTs do is strengthen their cores and their core strength and their arm strength. That's because they've lost a limb. So something's got to take up the slack, right? Other areas in their body have to work. Now, like just the amount of force, the torque that's exerted to move your body is just exponentially increased in other joints in ways that they've never been demanded to do. So it's just interesting that you were talking about that because it's so true. Just physiologically, it makes so much sense. Yeah.
No, that's a great point. I mean, I never thought of it that way, but I think historically we thought of the spine as one thing, but if you think about
Yeah.
the spine, it's numerous joints and numerous pieces that want to move. So it really is very similar to the situation that you were saying. And it's interesting that it took us so long to think about things this way when it was just right there.
Yeah, absolutely. Okay, so now let's kind of like just touch base into like the whole post-operative stuff that you wanted to discuss. Obviously, PTC patients post-operatively. What is your role in the post-operative care, and how do you work with other practitioners to make sure that patient outcomes are A-okay?
Yeah, that's another shift in the way that we take care of spine patients. Most hospitals now have an ERAS protocol, enhanced recovery after surgery. And that's not just for spine, it's for everything. But it has come into spine over the past couple of years. And, I was very fortunate to be involved in that process when I was at University of Michigan and seeing the difference that that makes with patients. I think standardizing the process, but having some individualization based on specific needs, obviously, but having some standardization of that process really helps a lot with getting patients to be in the hospital for the least amount of time needed, have the least pain possible, because that's what's going to get them up and be able to move with the physical therapist. So I think ERAS protocols, which include optimization of patients before surgery, whether it's their bone health, whether it's making sure that they're not anemic, whether it's making sure that they're as nutritioned as possible. Some even push for what's called prehab, right? Where you go through an aggressive physical therapy before to strengthen your core. And then it also is important, ERAS is important peri-op. So while you're in the hospital, making sure that we get you on the correct medications, making sure we do the appropriate blocks for what your surgery is, making sure you're getting the most appropriate, least invasive option possible. And then post-op, making sure that you're doing all the exercises that you need, making sure that you're getting the braces that are appropriate for you if needed, and making sure that you're being monitored as well. So a lot of new protocols include either a smartphone app where it's measuring your steps, or you're able to get to your clinical team right away, or whether it's wearable devices. So I think the postoperative care has changed a lot now because of all these ERAS protocols. And depending on whether you had a surgery that is a fusion versus a non-fusion, which includes all the decompressive surgeries and also the motion sparing surgeries, you're going to have different needs for stabilization versus just wanting you to be as flexible as possible and kind of stretching the muscles that have been injured during surgery. The length of time post-op that is important is also different depending on if you got a minimally invasive approach versus open, fusion versus non-fusion. So those are all very important factors to talk to your surgeon and your provider team before the surgery so you understand what you need to do post-op and have good communication between you and the provider team.
Yeah, that sounds all like it's super important. And, I think when I come back with patients, I usually don't see people immediately post-operatively. It's usually quite a little bit of time afterwards. Um, and I think that when they look back at their experiences with surgery, I'm talking even people who've had surgeries like 20, 30 years ago, like the ones that say that everything went well, it was always how their surgeon was. Like, how well did they respond to them? How did they explain everything to them? How did they coordinate and, even post-operatively, like be able to just care for them and show that empathy of you've gone through all of this and, just all of that makes such a big difference. And I know that you guys do a really good job in your practices, making sure that all of that works well so that the patient goes in knowing what they need to know and then come out feeling like, it was all worth it because it's a lot, right, for them to go through it. And so that's great. All right, Dr. Kashlan, do you have anything else you want to add to our discussion today that you want to share with our listeners that you haven't already touched on yet?
I think we talked about the main points, which is spine surgery is always the last option unless you have a significant neuro deficit, or the thought is that you are going to get one imminently. So those are the times that you have to do surgery. Other than that, it's all based on quality of life. We talked about wanting to see a surgeon that is equipped with all the new technologies if needed. But honestly, the most important thing is that you're seeing a surgeon, even if they're using older techniques, that is ethical, going to do the right thing, and is going to really care about you. Going back to what you're saying, I mean, that's the most important thing. It's more important than all these things that we talked about. But if you have that in a surgeon plus all the other things, then I think that's the person that at least I would go to, or I would send my family member to. Yeah, I think we talked about the motion sparing, we talked about the fusion versus non-fusion. So I think we've touched on everything.
Well, for listeners, I'm going to add Dr. Kashlan's information, his bio, his Instagram handle for LinkedIn and Twitter/X, all in the show notes so you guys can follow him and learn more about the amazing work. I'm sure this is just like a scratch on the surface, I'm sure, of like an amazing career, and also in New York now of all the things that you're going to do. So I'm personally really excited to follow that through with you and to see all the amazing things that you're going to accomplish. So thank you so much for being here today.
Yeah, thank you so much for having me. This is awesome.